Respected delegates, good afternoon. Thank you, Bindu ma'am, for giving me the opportunity. So, I'll be presenting a unique case of a 38-year-old woman who was referred for IOP control for performing penetrating keratoplasty. So, she had progressively decreased vision headache associated with eye pain, foreign body sensation, and headache. And she had a history of glaucoma for about 10 years. So, you have to note the age here. The patient was diagnosed with glaucoma at the age of 28 years. So her old report showed a cataract surgery which was done 10 years ago, followed by a trabeculectomy at the age of 30 years. She was on multiple glaucoma medications in the past. Family history, not anything specific by the patient, no trauma history. She was initially diagnosed as Fuchs' iridocyclitis, maybe due to the unilateral presentation of cataract and glaucoma. And I asked about the systemic history. That is when I got a catch. She gave a history of nephrotic syndrome complicating pregnancy, IUFD, and a surgery done for the right elbow in childhood, details of which are not available. On examination, the corrected distance visual acuity was 3 meters, counting finger in right eye with a pressure of 36 millimeters of mercury. Left eye was 6.6 with a normal IOP. So this is the anterior segment picture as you bulle. There is microcystic corneal bulle, which could be the reason for the pain. Also, the IOP was high. And IOL is well centered, and you can see a surgical PI post trap. It was kind of a failed trap with a flat bleb. Left eye examination was normal. Left eye, I could do a gonioscopy at that visit, and it was open angles, slightly densely pigmented trabecular meshwork with a normal posterior segment picture. Right eye fundus was hazy. I did a B scan. It was anechoic. There was no evidence of any retinal detachment or choroidal detachment. So considering the systemic history, I just did a random systemic examination and found this, which was little unusual. She had a pitting of nails, hypoplastic nails actually, in the hands and the feet. And even her facial presentation was a little different from the normal picture. She had high forehead with actually very lean body mass. So I just discussed with the nephrologist, and that is when we came to the diagnosis of nail patella syndrome, which is otherwise known as hereditary osteoonychodysplasia of Fonck disease or Turner-Kriser disease. Sorry. So the features suggestive in this case was pitting nails, facial features, elbow deformities for which she has done a surgery in the childhood, and the X-ray findings suggestive of bilateral iliac horns with subluxation of ulna, along with glaucoma. All these were suggestive of this syndrome. So considering a history of failed trap, I decided to go ahead with an RD, and as the patient is pseudophakic, a ciliary sulcus implantation, because anyway the patient would be taken up for PKP in future. But surprisingly, at 1 week, like you can see, there is a lot of improvement in the corneal picture. Like the bulle has resolved, the visual acuity improved from 3 meters to 624 with an IOP of 14 millimeters. At 3 months, this is the picture. There is still a very minimal corneal haze, but it was far better from what it was preoperatively and a normal IOP. Fundus showed a glaucomatous optic neuropathy with normal macula. So this is how it was preoperatively, and this is how it changed postoperatively. So such cases, when it comes to your clinic at a primary level, we should not ignore such cases, because most of the time when the vision is low, when the patient had multiple surgeries in the past, there was always a tendency to treat the patient medically and else consider that patient as one-eyed. But see, in such cases, if you refer such cases to the respective specialist, sometimes these wonderful outcomes can happen where there was a vision improvement from 3 meters to 6 tall. So nail patella syndrome is basically a rare disorder. Actually, I read about it more after this case. So it's autosomal dominant inheritance, which is basically due to mutation in LMX1B gene, which is responsible for the development of eyes, limbs, and kidneys, which are the 3 major organs involved. So this is a very rough picture about how a nail patella syndrome will present. So like I said, it is genetic or idiopathic, and these are the signs and symptoms. So mainly the elbows, nails, and the feet and patella will be hypoplastic. Facial features include a high forehead, there will be lean body mass, And open angle glaucoma is basically the most common ocular manifestation, though other ocular manifestations may occur. There are case reports which show angle closure and tightity also, but it's not very common. There is no cure, only symptomatic management. And how will you diagnose? So the basic catch here is the clinical presentation. So when a patient presents at a young age along with systemic features, you just look, you need that patient at least a random systemic checkup. You need not look at very thoroughly, but at least look how the patient looks when the patient comes to the OPD. If it is something different from how a normal healthy looking patient, then you have to do a proper systemic examination. And if it is associated with other ocular features like which could be of cornea, congenital cataract, which could be one reason why she underwent a cataract surgery at a very young age, or ptosis, telorism, or epicanthal folds. Genetic testing definitely will confirm the diagnosis, but with clinical presentation only you can make a diagnosis of such cases. So nail patella syndrome is a rare hereditary disorder with important ocular implications, particularly early onset glaucoma, and a high index of suspicion is essential in young patients. It's not about the treatment. You will be treating this patient like a primary open angle glaucoma, and that is okay. But imagine if the patient presented to you only with the ocular complaints and the systemic workup was not done. So you can save this, you can refer this patient to a nephrologist, so you can save the life of the patient from a kidney failure. Glaucoma is often aggressive and may require surgical intervention, and a multidisciplinary collaboration is essential for holistic management and better outcomes. Thank you.